You wake at 3 in the morning. Maybe it is a shoulder aching from the side you have been lying on. Maybe it is a burning sensation moving up from your stomach into your chest. Maybe it is your heart. Not pain exactly, just a pronounced awareness of it beating in a way that was not there when you fell asleep. Or maybe you notice that your breathing becomes slightly easier the moment you sit up. You adjust your pillow. You shift position. You try to fall back asleep. And you have probably never been told that the position you return to every night, the one your body has settled into over decades, may be working directly against the symptom that is waking you. Most people inherit their sleep position the way they inherit other habits. It feels natural, so they assume it is fine. Some have read that the left side is best for the heart. Others have heard the back is most neutral. Here's what almost no one is told. There is no single sleep position that is best for every adult over 65. The position that relieves one symptom may aggravate another or simply be unsuitable for a different condition. And the difficult part is deciding which symptom deserves priority when more than one is affecting your sleep. I am Dr. Henry Mercer, a specialist in aging medicine. What I want to give you today is a framework, not a universal rule. And to give you a sense of where we are heading, reflux generally favors the left side. Positional sleep apnea generally favors side sleeping over the back. Breathlessness when lying flat warrants medical assessment before you rely on a pillow adjustment as the solution. And for cardiac symptoms, the answer is more nuanced than most people have been told. By the end, one question will help you identify which position is most worth discussing with your doctor. Let me explain why there is no universal answer, and then we can move into the specific conditions. As we get older, sleep position can become more than a comfort preference. Gravity, lateral pressure, airway geometry, and fluid movement all shift depending on how your body is oriented. And those shifts interact directly with acid reflux, breathing, cardiac function, and joint health. The commonly repeated advice, left side is best for the heart, back is most neutral, is not invented. There is genuine research behind both ideas. Much of that evidence examines one condition at a time. It does not establish a single best sleep position for every older adult managing several conditions simultaneously. Everything discussed today complements your doctor's guidance rather than replacing it. If you are managing heart disease, heart failure, or a significant respiratory condition, any deliberate change to your sleep position is worth discussing first. Here is the myth, stated plainly. The left side is universally best for the heart after 65. Or, in its other common form, the back is the most medically neutral position. Both versions get repeated as universal rules. Both are incomplete in ways that matter for this age group. The left side claim has real evidence behind it for specific conditions. For nighttime acid reflux, it is genuinely well supported. For positional sleep apnea, side sleeping over back sleeping matters more than which side. And for heart failure specifically, the picture is more complicated than the conventional advice suggests, in a way that surprises most people. In positional obstructive sleep apnea, breathing interruptions are typically worse on the back. A position that appears neutral for the spine is not necessarily neutral for the airway. So if neither is universally correct, what does the evidence say? It says the right position depends on which condition is most affecting your sleep. The first condition is nighttime acid reflux, and this is where left side sleeping has the clearest evidence. Your stomach lies mainly on the left side of your upper abdomen. When you sleep on your left side, stomach contents tend to remain below the junction with the esophagus, and acid that does escape may clear more quickly. When you sleep on your right side, acid may remain near that junction for longer, making reflux episodes more likely to persist. For someone whose main nighttime symptom is heartburn or regurgitation, left side sleeping may help. Elevating the upper body or head of the bed can provide additional benefit. A wedge pillow or adjustable base is often more stable than a high stack of ordinary pillows, which tend to collapse through the night. This is one of the clearest position recommendations for adults with nighttime reflux. If reflux is your dominant symptom, the conventional left side advice is correct. Persistent or worsening chest burning still deserves medical attention, especially when the cause is uncertain. If the burning is new or unexplained, or comes with pressure, sweating, breathlessness, faintness, or discomfort spreading into the arm, back, neck, or jaw, do not automatically assume it is reflux. But when nighttime symptoms involve breathlessness or palpitations rather than familiar reflux, the position question becomes considerably more complicated. Heart-related sleep symptoms are where position advice most commonly fails the people who most need it. The conventional message is simple: the left side is better for the heart. But the evidence does not establish that as a universal heart health rule. The picture becomes particularly complicated in people with diagnosed heart failure. Some people with heart failure find the left side uncomfortable and naturally spend more time on the right. A small physiologic study found lower sympathetic nervous system activity in the right side position in certain heart failure patients, meaning the nervous system appeared less activated in that position. But this distinction matters. Those findings do not prove that right-sided sleeping treats heart failure, prevents cardiac events, or improves survival. They show that one position may feel and function somewhat differently from another in some patients. The evidence is preliminary, and the effect is not universal. A stronger awareness of the heartbeat on the left side may occur simply because the heart is closer to the chest wall in that position. But new, persistent, or irregular palpitations, especially with chest discomfort, faintness, unusual dizziness, or breathlessness, should not automatically be blamed on sleeping position and deserve medical assessment. Now, I want to say something directly, because this is the most clinically important passage in this video. A new or increasing need for multiple pillows, because you become breathless when lying flat is more important than any position preference. The same is true if breathlessness wakes you from sleep and improves when you sit upright. You may sit up for temporary relief, but do not treat this as a pillow problem. It may reflect fluid accumulation or changes in heart or lung function that need to be properly assessed. Sudden or severe breathlessness, especially alongside chest pain, faintness, confusion, bluish lips, or rapidly worsening swelling, requires urgent medical attention. Sleep position can be part of the conversation after the underlying cause has been evaluated. It is not where that conversation begins. The third condition is positional obstructive sleep apnea, and here the key distinction is not right versus left. It is side versus back. When you lie on your back, gravity can pull the tongue and soft tissues toward the back of the throat. In people whose sleep apnea is position dependent, this can increase airway obstruction and breathing interruptions throughout the night. Avoiding back sleeping may reduce events in this specific form of apnea. But the response varies between individuals, and position alone may not adequately control moderate or severe disease. It should not replace CPAP, an oral appliance, or another treatment prescribed after proper evaluation. Modest upper body elevation may help some people with both reflux and airway symptoms, though there is no single ideal angle that applies to everyone. The clues that sleep apnea may be a factor include loud or irregular snoring, witnessed pauses in breathing, waking with a dry mouth, morning headaches, feeling unrefreshed, and excessive daytime sleepiness. Those symptoms cannot tell you whether the apnea is position dependent. That distinction requires proper evaluation, often including a sleep study. If testing shows that breathing interruptions are substantially worse on your back, side sleeping may become a useful part of the treatment plan. The fourth condition is one the body usually signals clearly in the morning. Long periods of direct pressure can aggravate an already sensitive shoulder, including one affected by rotator cuff problems, bursitis, or arthritis, and leave it more painful the following morning. If that pattern sounds familiar, noticing which shoulder hurts and which side you were sleeping on, there are specific practical responses worth trying. A supportive pillow that keeps the neck aligned and reduces direct shoulder pressure may improve comfort. Alternating sides when possible distributes pressure rather than concentrating it on one joint every night. For some people, a semi-reclined position using a wedge or adjustable base may reduce sustained pressure on the shoulder. If both shoulders are affected, regardless of position, or if the discomfort is severe or new, that is worth raising directly with your doctor rather than managing with position changes alone. The fifth issue I want to address connects to something covered in a previous video on nighttime urination, and I want to be precise about what sleep position can and cannot do here. Fluid that accumulates in the legs during the day can return toward the central circulation after you lie down. This is one mechanism that can contribute to increased urine production during the night. In some people, part of that fluid shift toward the upper body may also affect the tissues around the airway. What the evidence does not establish is that sleeping on a specific side reliably reduces nighttime urination. The claims linking left side or elevated sleeping to improved fluid redistribution are not adequately supported to make a position recommendation on those grounds. If you experience frequent nighttime urination alongside ankle swelling, increasing breathlessness, loud snoring, or waking gasping, describe that combination to your doctor. Those symptoms together may share an underlying cause, and adjusting sleep position without addressing that cause may miss what is actually happening. Now the question I promised at the beginning. What symptom most reliably disrupts your sleep? If the answer is heartburn or acid reflux. Left side sleeping with head elevation is the most evidence-supported starting point and reasonable to try tonight. If the answer is breathlessness when lying flat, breathlessness that improves when you sit up, or new or irregular palpitations. This needs medical assessment before it needs a new position. Arrange that conversation first. If the answer is loud, snoring, waking unrefreshed, morning headaches, gasping, or witnessed pauses in breathing, side sleeping is a reasonable low-risk step that may help. But those symptoms cannot tell you whether the problem is position-dependent, and they warrant proper sleep apnea evaluation if they persist. If the answer is shoulder or joint pain on one side, try alternating sides with a contoured supportive pillow, or explore a semi-reclined position to reduce lateral shoulder pressure. If the answer is frequent nighttime urination, no specific side has been shown to solve it reliably. Fluid retention, sleep apnea, blood sugar, bladder function, and medication timing may all need to be considered. If the answer is more than one of the above, which is common after 65, this framework gives you the starting point for a specific conversation with your doctor about which condition most needs to be prioritized in your sleep setup. A brief note on what you can reasonably try yourself and what requires a conversation first. Reasonable to try on your own. Side sleeping instead of back sleeping for ordinary snoring, while arranging evaluation if there are witnessed breathing pauses, gasping, morning headaches, or significant daytime sleepiness. Adding a wedge pillow for head elevation. Using a body pillow or rolled blanket behind the back to prevent rolling onto your back during the night. Worth discussing with your doctor first. Any deliberate position change aimed at managing breathlessness, cardiac symptoms, or significant sleep apnea. And if a symptom repeatedly worsens in one position, that observation is worth bringing to your next appointment. Noticing what changes and in which position is more useful clinical information than a general description of poor sleep. Tell me in the comments, what position do you usually sleep in, and what symptom bothers you most at night? Your responses help shape the health questions this channel covers next. Most adults spend roughly a third of their lives asleep, often returning to the same familiar positions without asking how those positions affect their symptoms. As we get older, sleep quality influences blood pressure regulation, alertness, balance, and daily energy. But the goal is not to find one position that every person over 65 should use. The better question is this: does my position appear to influence the symptom waking me? Or is this a symptom that needs medical assessment first? For familiar reflux, shoulder pressure, or ordinary snoring, a careful position change may help. For breathlessness when lying flat, new palpitations, witnessed breathing pauses, or unexplained chest symptoms, the priority is evaluation. Knowing the difference is more valuable than being told simply to sleep on your left, your right, or your back.